Welcome to the EAU Podcasts. In this episode, UROONCO Bladder Cancer Associate Editors Dr. Grobet-Jeandin and Dr. Mertens interview Dr. Bukavina on managing high-risk non-muscle invasive bladder cancer.
Hi everyone, I'm Elisabeth Grobet-Jeandin, and together with Laura Mertens, we are delighted to welcome today's guest, Dr. Laura Bukavina from the Cleveland Clinic. Laura is a surgeon-scientist whose work is helping to redefine how we treat patients with bladder cancer. Laura, it's great to have you with us.
Thank you so much for having me.
Let's start with the fundamentals for high-risk NMIBC. Is BCG still the first-line treatment?
So the definition of high risk, and there's also, we practice a little bit differently within US and EU. So the guidelines within AUA only define high risk. There's really not a very high risk group. It's sort of all pumped into one. And then within the EAU guidelines, you have a group called very high risks. Okay. So generally anyone who's high grade, who's got large tumor bigger than 3 centimeters, who's got T1 or even TA disease is considered to be a high risk. A very high risk, most of us within neurologic oncology believe that's a true definition of very high risk, are also patients who are older, so over 75, large tumors over 3 centimeters, presence of CIS. Those are all what we consider to be very high risk. And yes, BCG is still considered to be the first line therapy. However, we are now shifting, I would say, over the last maybe 12 months, at least I can only speak from the US perspective, to where the BCG shortage, which is ongoing, has been pushing us towards alternative treatments as first-line therapy, which include gemcitabine docetaxel.
So there's been a lot of movement recently with new data coming from the CREST, POTOMAC, and ALBAN trial. Could you briefly walk us through what these studies have shown so far?
So as you mentioned, 3 studies. These are all BCG naive. So these are not BCG unresponsive trials. And then these all used systemic IO, so PD-1, PD-L1 inhibitors in combination with BCG. The CREST data was the first data that came out. And it looked a combination of sutimlimab, which is not really used in any other disease space, right? So we're not familiar with that IO therapy, in combination with BCG. It was done subcutaneously. So that's one of the things that very different from the past. It was done for 2 years. And what the data showed is it was a positive trial, 30% reduction in terms of events. So events were defined as recurrence, progression, cystectomy, and deaths. As you can imagine, the most likely scenario is a recurrence, high-grade recurrence. No deaths or certainly progressions were as often seen as the recurrences. So when we look at the hazard ratio, we're looking at about 30% reduction in recurrences. The progression data and the cystectomy data is not as clear. We know that there's likely less progression. There was not difference in progression, and the cystectomy data was not really available yet. So that's CREST. In terms of POTOMAC, this was a combination of durvalumab, which was done via infusion. So we're more familiar with durvalumab with other trials. This was done for 1 year. So instead of 2 years, this was 1 year plus combination of both induction and maintenance BCG for 2 years. That was also a positive trial. Also significant reduction in events or recurrences. And again, we don't know quite the data yet on the progression and cystectomy. Quality of life was okay. As you can expect, because the systemic therapy is done a little bit shorter than 2 years. This was only done for 1 year. There were less side effects compared to CREST. However, these are older patients, and about 60% of patients did need to be on steroids because of systemic effects. And then the last one is a negative trial. Is a great trial. I think very much, we have all been thinking about why is one trial was positive versus this trial particularly was negative. And I think it's just a trial design. I think the populations are very similar. But unlike the other 2 trials, which looked at 2 years combination of maintenance and induction BCG, this was limited to 1 year BCG in combination IO-based therapy.
What do you think will be the most promising strategy?
Most promising strategy, it's hard to say because as urologists, I think it's good to have that ability to offer to patients. But if you look at the trial designs across the board, some of those patients, for example, are TA high-grade patients, older population. We have to think, are we really benefiting these patients by just reducing the 5% reduction from recurrences and providing 13% systemic toxicity, and really focus on the patient that is, if there's a very, very high risk group, maybe that would be the patient population that we would potentially consider doing the combination therapy. We don't have biomarkers in any of these groups. And I hope perhaps these trials will start releasing some of the biomarkers. And we can help understand which is truly that subgroup population that will benefit the most. For example, CREST, CIS had a signal, right? So CIS was the group that had pure CIS, very high risk group, and had what we call the most benefit from this combination. This was not seen in Potomac. Now, not quite sure why. But is that sort of a group that we should be targeting? Are those really high-risk CIS patients?
So that really remains an important question. Who benefits most from this intensified treatment?
Exactly. And what ultimately, what do the patients want? Are they willing to take the toxicity, lifelong toxicity, right? So we're talking about lifelong toxicity, diabetes, potentially thyroid problems, and potentially some life-threatening toxicity, pneumonitis, colitis, just reduce their risk of recurrence by 5 to 7%.
Do we know anything about patient preference here?
Not yet, but if you remember the cysto trial that was done at AUA last year, presented, it was a great trial funded by PCORI and done with Al Gore and Angie Smith, and that looked at patient preference to bladder preservation versus subsequential therapy versus cystectomy. And what they found is that if the patient chooses cystectomy versus a patient who chooses bladder preservation, the quality of life actually is a bit better with cystectomy. Aside from sexual function, which we understand, the actual quality of life, the financial toxicity, the emotional toll is actually better in patients who choose cystectomy.
Many of these new treatments come also with high costs and logistical issues, How do we balance innovation with access and practicality in a real world care?
Huge problem. I think US makes its own problems a lot of times. We approve a lot of drugs based on a very limited data in terms of, for example, recurrence, but no data in overall survival differences. All three of these trials showed no difference in overall survival, right? I think this is going to be a discussion that we're going to have for the next couple of years because our costs in bladder cancer are escalating exponentially. Are we actually improving the quality of life and the survival in these patients? I'm not quite sure we have that data yet. Most of these drugs are so new, right? Most of these drugs, think about even the first Pembro trial in BCG unresponsive, 2022? That's not that long ago. We don't have enough data to actually show that it's improving survival in these patients to warrant the cost that is associated with it.
Should that be taken into account in trial design?
I don't think that should be taken into consideration for trial design. I think quality of life for patients should be one of the things that the trial should be focused on as well. I think it's up to us as a physician seeing them to take that into consideration. For example, while the therapy is available, for example, we'll take one of the BCG unresponsive medications. We won't talk about which one. But when my patients come in, I always talk about the cost. I always say, this is how much it costs. This is how much your insurance may pay, but you may be stuck with a payment for this. And I don't want you to feel like you have to do that because I said that's the best treatment for you.
Yeah.
Because if you're going to be struggling, we can find alternatives for you. And that's a discussion you have to have with patients because they feel like my doctor said so, I have to do it. And I always have to say, no, you don't. If you can't afford it, we don't need to do that. We'll figure something else out.
Actually, this is a really new perspective for me. How do patients respond?
They say, that's great. And I tell them, send me a message, how much this is going to cost you.
Okay.
And if it's acceptable or not, and we'll talk. We'll chat on the phone. And I say that also with some of the new biomarkers that's currently available. So we have a lot of AI, we have ctDNA, right? And most of these are, 90% of it is covered by insurance. But if you're saying 90% out of many, many thousands, it's still a good amount of money.
Yeah.
So I always say, If this costs you more than this, I need you to send me a message. We'll figure something out.
Beyond your clinical and research work, we've known that you built a remarkable record in philanthropy, operating abroad. What drives that commitment, and how has it shaped your perspective as a surgeon scientist?
So it's abroad, but really, we go to Ukraine about twice a year since the conflict with Russia started. And that's primarily because that's where I'm from. So it's a little bit of also, I guess, selfish reasons. It's been phenomenal to work with people who have no connection to Ukraine. So I really cannot take credit because I'm from there. I feel sort of that connection to it. But the fact that our last mission trip, we had 6 surgeons come with us. They have no connection to Ukraine whatsoever. Just the connection to me and helping people come with us and do reconstructive surgeries, do cancer survivorship surgeries. And it changes you because you understand that what you have here or US is exponentially more than what people have in the war conflict zones, right? So what you consider to be a good quality of life, what you need to get cancer, and our patients need chemo, it's never a question of them getting chemo. But when you're in the war zone and there's no chemo drugs available and you have cancer, there's no one to call. There's no ombudsman to call. The supplies are limited. We bring a lot of our own surgical supplies. And it changes you as a surgeon because when you go back, you realize how lucky your patients are and how lucky you are. And it changes you because you start to treat disease a little bit more financially savvy. I think you understand that. Over a long time, some things don't need to be done because ultimately they don't necessarily help patients. We don't need 500 types of sutures to do a surgery sometimes.
Yeah, it changes the whole perspective of surgery at all.
Yeah.
Thank you very much for this interview. Very inspiring, very clear also.
Thank you for having me.
Thank you for listening to this episode of EAU Podcasts. To keep up to date with bladder cancer developments, visit our educational platform UROONCO Bladder Cancer. For more EAU podcasts, please go to your podcast app and subscribe to our EAU Podcast channel for regular updates.